is like I didn't learn this in physics, I promise you. And I learned it really just in preparation for teaching women's health. But I was shocked at all the different things that happen. And we know that moms go through a ton of changes during pregnancy. But who knew that their kidneys actually get larger, like physically get larger? I was talking to my sister had 5 kids, and I'm like, talking this morning, I was like, did you know this? She's like, nope, I had no idea that any of those things happen. So this will be interesting. You can go home and over dinner tonight we can talk to your spouse about, do you know all these things are going to happen? Like, no, don't tell me. But this is usually what is true. The day you're well pregnant, people think you're thinking of the baby, and oh, I can't wait to have the baby, and all the things, and the giggles. But really it's like, I want a margarita, and I need a martini, and can I get the biggest hot dog ever without having reflux, and abdominal discomfort. Oh, and sushi's on there as well. You have TLOs and ELOs. As a reminder from last week, if you have somebody that comes in, she's 27 years old, she has questions about becoming pregnant. She's not currently pregnant, but had one miscarriage at 9 weeks and one vaginal delivery at 39 weeks. You want to think of what about her GTPAL status is. So if she, how many pregnancies has she had? 2 pregnancies. She had miscarriage and she had one at 39 weeks. So we have our G2. So what is our first after the P? What does our first one stand for? Term. And what's our next one? Preterm. And after that, abortus. And then living. So how many living does she have? 1. How many term does she have? 1. Any preterm?
0.
0. Abortus? 1. So G2P1 0 1 1 would be your GTPAL status. Okay. I'm not gonna harass you too much for that, because I can see out there the haziness in your eyes. What did she just start off with? All right. She comes back 2 months later for her first prenatal visit. In her initial screening, so she's coming back at 8 to 12 weeks or so, 8 to 10 weeks for her initial OB. What is part of that initial screening of these things that we have on here? Oh, Lord. Ultrasound to establish gestational age. So quad screen is only going to be done if triple screen is abnormal. Triple screen is typically only going to be done if your ultrasound is abnormal and it shows that thickened nuchal translucency. Or, yes, if mom has a history of having a chromosomal abnormality, then we consider triple screen. But quad screen doesn't tell you unless triple screen is abnormal. Leopold maneuvers, we're using those later on to assess fetal lie and presentation. And then diabetes screening, 24 to 28 weeks is when that occurs. And now we're going to just do an ultrasound to establish gestational age in concordance with the last menstrual period. So pregnancy affects really almost every part of the female body. Most of these changes are going to be physiologic in nature and are basically what we call an adaptation process as mom gets further and further along in the pregnancy. Baby is growing, placenta is growing, mom needs to accommodate for baby growing and for placenta growing. One of the obvious things that cause the issue is the mass effect that baby is going to have on mom and mom's organs. It's going to push things up, it's going to push things out to accommodate this growing baby. A lot of these organs are going to have increase in blood flow to accommodate mom's growing body and also to accommodate the growing fetus. We've got hormonal changes, lots of increase in estrogen, increase in progesterone as well. And because of that, we have a lot of multiple systems that are involved. Connective tissue changes occur to allow mom to adapt to this growing baby. We have changes in our electrolytes. We have changes in our sodium, changes in your magnesium as well. We have actually an increase of about 50% in total circulating blood volume to accommodate the growing baby. So all of these occur as a result of this growing baby. Now, once mom delivers a baby, usually within about the first 2 to 3 months, things have settled down and then mom's body has gone back to the normal pre-pregnancy state. For the most part, there are some changes that persist, like stretch marks, unfortunately, those never completely go away. If mom gets a ventral hernia or diastasis rectus, that doesn't necessarily go away, but everything else goes back to normal. So let's talk about some of these specific changes. So cardiovascular changes. Again, as mom becomes more and more pregnant, that baby is growing, that fetus is growing, it's going to start to displace the heart. And it displaces the heart upward and to the left a little bit. So on chest X-ray, we may see an enlarged cardiac silhouette. On EKG, we may see a left axis deviation. Okay? And that's because, again, the heart moves to the left a little bit. Heart sounds change. 90% of these females that did not have a murmur before pregnancy, 90% will have some sort of systolic murmur. That's a lot. But 20% might have a really soft diastolic murmur. But really, when we think about diastolic murmurs, we think about that as pathological. It's not normal to have a diastolic murmur, regardless of if you're pregnant or not. About 20% or 10% can have this whole systolic murmur, or continuous murmur as well. So we want to know that when we're listening to these patients' heart, we're like, oh, is this a murmur I hear? It probably is a murmur that you hear, because 90% of these patients will have a murmur that they no longer did not previously have. That third heart sound, which we hardly ever hear, becomes very distinct in pregnancy, especially in that second and third trimester. We have other cardiovascular changes about 5 weeks. We're going to have increase in cardiac output, decrease in systemic vascular resistance, but ultimately an increase in heart rate. Even early on in pregnancy, by about the end of that first trimester, we can expect that the heart rate is going to increase about 10. Again, that's important for a patient that comes in and their heart rate, resting heart rate is 95. Now they're 105 to 110 with some, some exertion or shortness of breath, a little bit of chest pain. Is this a pulmonary embolism? Because now we can consider them tachycardic, but really we expect that increase in heart rate by about 10. So make sure you understand that. You have a decrease in blood pressure. And that starts very early on in pregnancy. By 6 to 7 weeks, we'll have a decrease. But the lowest is going to be around that middle portion towards the end of the second trimester, between 24 to 26 weeks. That's going to be called our nadir. That's the lowest dip. And kind of just a little U and then back up to normal. But in general, blood pressure is lower in pregnancy. We talked about this already, which means that if someone comes in, they're 140 over 90, that is very concerning, because that is very high considering they should have normal, lower than normal blood pressure. Okay, by about 10 to 20 weeks, we're going to have an increase in the overall circulating blood volume. Now, this is a hemodilution, meaning the blood is just thinner, okay, but there's more of that volume. So it's about 50% increase. And when we are seeing these patients, we want to talk to our moms about how maternal posture can affect hemodynamics versus mom sitting versus standing versus lying down. Okay? And how does that affect the heart rate and the blood pressure and the stroke volume? Mom laying down, especially if mom's laying on her back, is going to cause some compression of those great vessels, and that's going to decrease your heart rate and decrease the blood pressure even more, which can cause some complications when mom goes to stand up. So we talk to our patients about appropriate positioning. Usually we're going to have them up on the left side. Again, as baby becomes bigger and bigger, mom becomes more pregnant, we're going to have increased pressure on the, typically on the blood vessels like the vena cava or the femoral veins or the pelvic veins. So primarily we're talking about the veins versus the arteries. And what that can cause is stagnation of blood. Stagnation of blood usually is improved by mom laying on her left side, which she's laying on her back for a prolonged period of time. It can increase lower extremity edema, can also increase the risk for DVTs and PEs. And mom is already at an increased risk because of the amount of circulating estrogen that she has. So now if we have compression on those vessels because she's constantly laying on her back, it increases that risk even more. There is something called supine hypotension syndrome. Supine hypotension syndrome is for about 10% of patients. And that is moms that usually, because they're laying on their back, they're going to have pressure on those great vessels. When they go to stand up, their blood pressure significantly drops and they pass out, or they feel like they're going to pass out. So again, we encourage mom to lay up on the left side. And the reason we lay on the left side is because as that baby grows and uterus grows, it tilts to the right a little bit. So if mom lays on her right side, all we're doing is pushing more pressure on those vessels. So we're gonna have mom, remind mom, every time we see them, don't forget, don't lay on your back, you're gonna lay on your left side. Now, if you're in a position that you're seeing these patients come in that are fairly pregnant, maybe they were in a car accident, or they're coming in to be seen for abdominal pain or something else. Make sure that if you're managing these patients, you remind them during their hospital stay or during their, if they're in their urgent care, that they're laying on their left side and not lay straight on their back if they're in a bed. We especially see that if patients come in, again, in a motor vehicle accident, they're usually in a C-collar, and we have them laying directly on their back. That's not good. Take a pillow, take a towel, put it under, even if they're on a spine board, put it underneath that spine board and get them off of their back so we can reduce the chance of them having compression on those great vessels. Okay, that's all you need to know for the cardiovascular system. Let's go on to the respiratory system. So we've got a couple of things going on here. We know we have increase in estrogen, we also have increase in progesterone. Now, increase in progesterone is going to increase oxygen consumption. So what we need to have for that, to support that, is increase in tidal volume, increase in minute volume. Overall, though, our total lung capacity is unchanged. And the reason for that is even though the baby is pushing the diaphragm up, it's pushing the heart up and actually pushing the lungs up, the chest wall itself expands out by about 6 inches. Okay? So if moms were to look at themselves at the beginning of pregnancy, and then we go to that second and third trimester, they can see that their chest wall is actually much bigger by about 6 centimeters, 6 inches greater than normal. So that's in the anterior, posterior, and the transverse position. Okay? We have an increase in the diaphragm is going to actually be elevated by about 5 centimeters as baby gets larger and larger. The overall, not only does the total lung capacity not change because we have that expansion of lung, respiratory rate also does not change. Now, that being said, moms often have a feeling of that they're breathing faster or difficulty catching their breath. And that's really not really due to lung changes, but it's due to metabolic changes. Okay? So what we're going to see is these patients have this slight hyperventilation, where they feel like they're breathing more, but their respiratory rate is still between that 12 to 16 or so. We have this respiratory alkalosis of pregnancy that occurs, so just a little bit alkalotic on their pH. Okay? But you see their PCO2 is decreased and their PO2 is increased. We call that. Did you guys learn the terminology ROME? Okay, so respiratory is opposite metabolic and even. So this is your opposite. Your PCO2 is down and your PO2 is elevated. Again, most of the time we're not doing BBGs on our pregnant patients unless they come in. Again, they were in a car accident or they're having chest pain or shortness of breath. You may get a BBG. If you notice that they have this respiratory alkalosis, that is a normal part of pregnancy. And that's all you got to know. So what I would focus on for this respiratory, tidal lung capacity is unchanged. We have this expansion of the thorax to accommodate the change in the lungs. Respiratory rate unchanged. For the heart rate, increase in heart rate, decrease in blood pressure. Right? GI system, a lot of GI changes that occur. That baby is growing, and what is it doing to the stomach? What is it doing to the intestines? Intestines are going to be pushed out. Stomach is going to be squunched up in there. So here's a normal pre-pregnancy stomach, nice and big. Okay, but as baby grows, it's going to push that stomach up, and the stomach is all squished up in there. And what that does is it changes the capacity of that lower esophageal sphincter. And so that lower esophageal sphincter, we have a decrease in tone. So if you have increased pressure from below and decrease of that esophageal sphincter tone, what that does is forces that lower esophageal sphincter open. Well, where is that acid from the stomach going? But into the esophagus. So it increases the patient's risk of esophageal reflux, especially the further they get into this pregnancy and the bigger they get. Oftentimes, we also have a decrease in esophageal peristalsis. So not having mom may have she feels like it's a difficult time getting the food down or keeping the food down. So we talk to our patients about frequent small meals. And you talk to them about raising the head of the bed at night. Don't eat just before you go to bed. If there are certain foods that increase your symptoms or gastroesophageal reflux symptoms, try to avoid those foods. And then oral antacids. There are many pregnant women that have oral antacids at the bedside, and they're popping those like candy throughout the pregnancy. And that's okay, because what oral antacids have in it that mom needs? Calcium, and baby needs calcium. So that's okay. They probably can't really overdose on them. They don't taste great, so they probably won't. But just know if it's a midnight run to the store for some antacids, it's okay, because mom needs it and baby needs it as well. Gastric emptying time overall is unchanged throughout pregnancy, except for around the time of delivery. That's a high stress time frame. And so around the time of delivery, we actually have a delayed gastric emptying. Appendix. So appendicitis in pregnancy can be really tricky, because that appendix, the further along mom gets in pregnancy, gets pushed up and gets pushed over to the side. So you may have an appendix all the way down around the flank area. So when it happens, mom comes in with flank pain, we might think it's something like a kidney stone, okay? And so we're going to check the urine, there's no blood in the urine, it actually could be appendicitis. We need to have a high index of suspicion for these patients, especially in that second and third trimester as that appendix is displaced. Pregnant women have a higher propensity for gallbladder disease, so cholelithiasis, which is gallstones, and cholecystitis, and that's because we have a decrease in gallbladder contractility, and we have an increase in cholesterol saturation and decrease in emptying as well. So mom is holding on to bile, and the gallbladder is not able to really get rid of that. The other thing mom can have is something called intrahepatic cholestasis and pruritus. Intrahepatic cholestasis and pruritus is due to retained bile salts, again because the gallbladder isn't emptying very well. And these patients will come in with a severe itching. So they have itching all over their body, but no rash. They oftentimes will have a little bit of a jaundice associated with that, but if they come in earlier on in pregnancy, this can occur in the first trimester, but usually we're going to see this in the second and the third trimester. If they come in really bad itching, even if you don't see jaundice, and they're like, I am scratching me, and it's all over the place, and you don't see a rash, that is intrahepatic cholestasis. It's very uncomfortable for the patient, but doesn't really cause any long-term complications for the pregnancy. We do have some liver changes. Overall, just a little bit of enlargement of the liver, but what we will see is a change in our liver functions. Okay? So ALK phos increases due to placental production of alkaline phosphatase. Okay? And then we have a decrease in our AST, ALT, and our GGT, and also our bilirubin. Those are the decrease, and that's oftentimes due to the increasing circulating volume as well. HCG levels. We know in that first trimester we have a significant rise in our HCG levels every 2 days. Okay? We have about a 2.2 times increase in our HCG levels. So in that first trimester we have a significant quick increase in our HCG, and then at the end of that first trimester we have a slight decrease, and that plateaus for the remainder of the pregnancy. Now, because we have that increase in HCG pretty quickly, a lot of patients are going to have what we call morning sickness. It's not really morning sickness, it's all day sickness. But they feel that nausea, and they have several episodes of vomiting throughout the day. Okay? Usually that starts within the first month and again lasts throughout that first trimester. The majority of patients, as they get into the second trimester, these symptoms become much better, although they may still have some intermittent nausea. It's not that every single day nausea and vomiting. Okay? Very seldom do they have any electrolyte derangements associated with this. Very seldom do they have ketonuria, which is indicating dehydration. So there are times that does occur where they do have electrolyte derangements, and they do have ketonuria. We call that hyperemesis gravidarum, and we'll talk about that more when we talk about pregnancy complications. But for patients that just have this regular nausea and vomiting, I'm vomiting 1 or 2 times a day, otherwise they feel okay, we can also talk to them about frequent small meals. There's a medication called pyridoxine, or B6, that we typically prescribe for these patients. We can also consider diphenhydramine if needed. The last resort would be antiemetics, because antiemetics can cause complications with the baby and complications in pregnancy. So also, how do antiemetics affect the heart? You guys remember? Look at it prolonged. And prolong the QT as well. So antiemetics, unless we really have to, we do not want to give them. Pyridoxine, Unisom is another one, so oftentimes the OBGYN folks will give them a combination of pyridoxine and Unisom to take for nausea and vomiting. We have renal changes. As I mentioned earlier, the kidney actually increases in size by 1 centimeter. Okay? We have increase in GFR. If we have increase in GFR, that means mom is peeing all the time. Increase in urinary frequency, increase in renal blood flow, and that is occurring very early on in pregnancy. By the end of that first trimester, we have an 80% increase in renal blood function. So we're going to start seeing an increase in size. And what that results in also is hyperfiltration. So hyperfiltration, so we're going to have this hyperkalemia and just hyperdilution, which ultimately we can see a decrease in serum protein, but also a decrease in serum creatinine. Because we're peeing a lot, so our creatinine is going to be very, very low. Okay? Again, that is important because mom comes in and she has protein in the urine, okay, and especially in the setting of a blood pressure that's kind of a little bit, maybe even that the high 130s over 80s or so, she's starting to spill protein. That is concerning that she may be developing preeclampsia, especially if we see that in that second trimester of pregnancy. We have a ton of metabolic changes that occur. Okay? A woman's metabolic rate increases during pregnancy, and that's why it's important that we're talking about mom eating nutritious foods and having those frequent small meals so we can have this constant supply of nutrition to the baby. We know that weight gain is a thing in pregnancy, and we want moms to gain weight. Okay? It's not just about what mom's eating, okay? It's also about the fluid that mom's retaining. Average weight gain for the person going with a normal BMI, 25 to 35 pounds. Most women are going to gain about 27.5 to 28 pounds in pregnancy, and that is completely normal. We have this water retention, especially as mom gets into that second and third trimester. Okay? Ultimately, this is from not just mom retaining water, it's from the baby, it's from the amniotic fluid, it's from the contents, the water contents of the placenta as well. So most of these patients are going to have some sort of edema towards the end of the day. And we call this this end of day pitting edema, or this dependent edema is what you'll often see. And that's not unusual. So when patients come in and they say, I've got this swelling in my legs, it's important to ask them, do you notice that in the morning it's better and it gets worse throughout the day, or is it bad all the time? Because if it's bad all the time, now we've got to figure out why are they consistently retaining fluid. And again, if you're in your second and third trimester, preeclampsia will cause you these moms to retain fluids. We check a urine, check liver enzymes, things like that. But otherwise, this dependent edema is very normal for them to have that swelling at the end of the day. Carbohydrate metabolism. We have this change in our carbohydrate metabolism during pregnancy, again, to allow continuous supply of nutrients to the growing fetus. As a normal pregnancy, these patients are going to have this fasting hypoglycemia. So mom is not eating for a few hours, blood sugar is going to drop a little bit. Once she eats, she gets this postprandial hyperglycemia. So now blood levels are up, and they're going to stay up for quite a while, so we can support baby and provide the nutrients and the glucose to baby. And they have the hyperinsulinemia as well. Right? And as long as this occurs, we're not going to have these prolonged time periods where baby is not getting nutrients and mom is not getting nutrients. The other thing we're going to see is we talk to our patients. Sometimes they'll talk about, well, you know, I'm going to have to do this fasting, maybe oftentimes for religious purposes. We want to talk to our patients about fasting is not recommended in pregnancy. And what we're doing is mom is fasting, we're forcing mom, we're forcing baby to use ketones as nutrients. And that's not going to supply baby for very long. Baby needs glucose. And mom, the only way baby can get glucose is through mom. So we talk to our patients about eating frequent small meals throughout the day to allow this constant supply of nutrients to the baby, and that's why we have this carbohydrate metabolism change and how it's metabolized. Okay. Electrolyte and mineral changes, sodium, potassium. So really we have this increase in GFR we talked about, we have decrease in creatinine, and what that's going to result in is a slight decrease in our sodium. But really, it's still typically within normal range. So sodium normal 135 to 145. So we're around that 135 to 136 level for our sodium. So nothing really significantly decreased, but on the lower end of normal. Magnesium levels decrease in pregnancy. Any idea why? Actually, placenta and baby both need magnesium. So the placenta is going to pull some of that magnesium to the lower levels. But that's okay, because we can compensate that for that with prenatal vitamins. Prenatal vitamins have magnesium in that, and so mom can use that. And all moms are recommended to take prenatal vitamins. Iodine, the requirement for iodine increases during pregnancy because the baby's thyroid has to grow. Okay, so we want to make sure that mom is again taking not only prenatal vitamins, but how else can she get iodine? From salt. Right? On the salt it says iodized salt, right? From salt. But most foods have iodine in it as well. Even fruits and vegetables have some degree of iodine in them. Okay? We want to make sure that we understand that we do have some thyroid changes that can occur. So we have increase in maternal T4 and increase in fetal thyroid production in that second trimester. That's going to pull and use some of that iodine as well. And then increase in iron requirements as well. This is to help prevent fetal anemia. Okay? Prenatal vitamins are chock full of iron, and then mom can get iron supplementation in foods as well. Calcium and vitamin D, total maternal calcium and vitamin D levels decrease in pregnancy, and that's because baby's using those levels, using that calcium, using that vitamin D for the baby skeleton to appropriately develop. Okay? And that's why it's important we talk to our patients about not only taking their prenatal vitamins, but we want to talk about calcium and vitamin D supplementation. Usually 1,000 to 1,300 milligrams of calcium is recommended in pregnancy. Skin changes. 90% of women are going to have some degree of hyperpigmentation. Now it can occur on the face, on the neck, on the abdomen. We have something called linea nigra. This bottom picture is a picture of linea nigra. And that is thought to be from increase in melanin producing melanocytes by the placenta. The placenta kicks out those melanocytes, and that's what's thought to cause this hyperpigmentation. So we can have this linea nigra, and this typically will almost completely resolve after pregnancy. Some patients will have still a faint line of this brown after pregnancy, and the majority of them will completely resolve. Some patients will have this chloasma or the melasma gravidarum, and that is hyperpigmentation on the face or on the neck. Okay, we can see here in this top picture. The skin around the areolas, the genital skin, also becomes hyperpigmented, especially in dark skinned females. It is more accentuated in those patients. Again, no specific treatment for this. They can use creams and all that. It's not really going to fade it. It's just going to go away as the hormone changes go back to normal after pregnancy. Okay. And this is the chloasma or melasma in a light-skinned person. It looks like they just have super red cheeks, kind of like slap cheeks, but that is that hyperpigmentation. You can see it not only in the cheeks, but you can see on the chin area here and kind of in the forehead as well. We can have something called angiomas or telangiectasias, these vascular spiders. Okay? And this is due to increase in progesterone and increase in estrogen as well. Oftentimes this is seen on the face, on the upper neck, or on the upper arms, or even on the chest area. Nothing to do, they're not painful, and again, these typically resolve after delivery of the baby. And another phenomenon a patient's going to have is they can come in and have these, like they say, my palms are just like, they're on fire, they're always red. And it's because we have this increase in metabolism, but also increase in progesterone, and moms are hot. And they're trying to dissipate this heat, and that heat can come out through the palms of their hands. So those hands get hot and red as that heat is trying to be dissipated out through the hands. This is the striae gravidarum. These are also called stretch marks in pregnancy. In a patient that's currently pregnant, they're typically red or light pink in color. Okay, and then after deliver the baby within a few, 3, 4, 5 to 6 months, that redness goes away and they become more silvery. So the multiparous women, we can see that there's more silvery or glistening in appearance. Okay? But currently pregnant, they see red. Now, some patients will complain of some itching in those stretch marks, especially as mom becomes more and more pregnant. We have that increased stretching of the skin. No rash is associated with that. It's just really the skin that's stretching and the irritation of the skin that's causing that itching to occur. There are no long-term complications associated with this, and despite all of the infomercials at midnight that we're looking at, there's no creams that prevent this from happening. The majority of patients will have this to some degree. So keep the credit card away from your wife at night. And she's like, I need this is looking terrible. It's not going to help. It's not going to help. It's going to be fine. Right? All right, musculoskeletal system changes. As the female becomes more and more pregnant, we're going to have this progressive lordosis. She has to accommodate. She gets off balance. So mom's out here at 36 weeks. If she walked upright, she would fall straight forward, right? So mom has this lordosis that develops and a little bit of kyphosis that develops as well. And that's just to accommodate so mom can actually walk often without waddling. Okay? Unfortunately, about 36 weeks they're going to waddle anyway, because the other thing we have is we have this increase in joint mobility and laxity. That's okay. That is to accommodate a baby that's getting ready to come out of the maternal pelvis, right? We want those joints to be a little bit lax. We want those ligaments to be lax as well to allow mom to be able to successfully deliver this baby. But the problem associated with this is uncomfortable for mom. Tends to be painful for these moms further and further into pregnancy. Okay? Once mom delivers, within about 3 to 5 months postpartum, the ligaments and the joints go back to normal, but it does take quite a bit of time. So we want to make sure we educate our patients about that and let them know that yes, you have this laxity now, it's going to return to normal, but many of the things that they're going through is going to be within the first 4 to 6 weeks. It's going to be a little bit longer than that, up to 3 to 5 months. Sometimes these patients will have numbness and tingling in their arms, and that is from pressure and change in their from that kyphosis. Sometimes they'll have numbness and tingling in their back, even down to their legs, and that's again because of that lordosis. But 70% of patients, and probably more than that, are going to have a degree of back pain the further and further along they get into the pregnancy. Yeah. This is probably not a big deal for us to think about this in that first trimester or early mid-second trimester. But mom comes in at 34 to 36 weeks and has back pain, we've got to make sure that this is not contractions, okay? Because contractions can occur as back pain as well. So just keep that in mind. So some patients will recommend maybe a pillow on their back while they're sitting. Some patients will use an abdominal binder if they can tolerate that. And if we're going to give them medications, it's going to be Tylenol or acetaminophen. Anti-inflammatories are not recommended in pregnancy. Okay? Now remember that. Tylenol in pregnancy, you need to avoid any sort of anti-inflammatories. If we need to give a muscle relaxant, something like cyclobenzaprine is technically safe in pregnancy, but really we do not want to give that unless it is necessary for mom to be able to function. Right? Baclofen can also be given, but not typically recommended unless we have no other option. What we do recommend, in addition to the acetaminophen, is encouraging our moms to stretch, encouraging our moms to exercise. Okay, we talked about preconception counseling. Part of that preconception counseling is to increase your core. So the core stability is important, and that helps these patients have a much more successful pregnancy, and a pregnancy where they have a lot less complications. Well, if they need to, physically, you can give them a consult to physical therapy. If the physical therapy can help with their back pain, chiropractor can help, but I'm really, really cautious with that for these patients in their second and third trimester. Are you going to start doing any sort of manipulation, especially of their neck? Like, in general, I am not a fan of chiropractic at that. I have seen vertebral artery dissection and carotid artery dissections, not infrequently. So I've probably seen that in my 25 years in emergency medicine. I've probably seen at least a dozen times. That's a lot of vertebral artery dissections from manipulation. Any idea how those patients present? Because they actually don't present with neck pain. You guys know how they present with vertebral artery dissection. Or sore throat. Sore throat. Guess what? You're in the middle of cold and flu season. You got a sore throat? You probably, let's check you for strep negative, it's probably just a virus. But they had manipulation 5 days ago. So I would not recommend that, but physical therapy, I'm totally on board with. Okay, round ligament pain. This is awful for patients. This is awful for patients. And it's awful for providers as well, because again, think about where the appendix is located. So round ligament, there's a ligament that goes from the side of the uterus down to the pelvic bone here. Okay, and as baby grows and the uterus grows, it's going to start to stretch this ligament. So patients typically will come in that second trimester of increasing pain, and sometimes like all of a sudden they have this pain, and the pain is horrendous. And it's on both sides, but usually right greater than left. And it could be round ligament pain, and most of the time it is round ligament pain. But many of these patients, when they come in, the number one thing we think about is this their appendix that's causing this, especially since it occurs more on the right and it does not on the left. Okay, so these patients oftentimes will get blood work, they'll get an ultrasound, they'll get an MRI to try to identify, is this appendicitis, or is this in fact just round ligament pain? It's hard to say on examination because you can't feel the ligament, and the area that they have the pain is the same area that the appendix is. So just keep it in mind for these patients in the early second trimester. If it's a gradual onset that's going ongoing for the last several days, it's probably round ligament pain. And for these patients, there's nothing really specifically to do. You run them into stretch. They can take acetaminophen. Heating pad, warm bath tends to help. And usually within a couple of weeks, this round ligament pain goes away. Some patients will have it throughout the entire second trimester, but most patients usually about 2 to 3 weeks and it goes away. If they are working, you can do some activity modification, so limit their amount of lifting, limit their prolonged standing as well. Ventral hernia. This is a diastasis recti. Diastasis recti typically will occur in that second and third trimester, but I have seen it even as early as the first trimester. And what happens is, what causes this is that you have a separation of the musculature right here. The rectus muscle gets separated. You can see the picture here. This is normal here. In the middle picture, the rectus muscles get separated, and now we have this ventral hernia. So this is a person that is lying flat here, and then she does a partial sit up here, and you can see this extensive bulge here. This is a ventral hernia. This is one of those things that does not typically get better after pregnancy. And once mom delivers, those muscles do not typically go back together, and they have this persistent ventral hernia. The unfortunate thing about this is it's considered cosmetic, so most of the time they will not be offered any sort of surgery to treat this. So if your mom has discomfort, pain associated with it, they will potentially think about it, but usually that's going to be several months after delivery to see if she has any resolution. So sometimes you'll come back to almost completely together where they have just a little bit of a bulge, but it rarely goes completely back to normal. All right, the GU system. We got some kind of weird changes that go on with the GU system. Early on in pregnancy, we're going to start to have some softening of the cervix. Okay? We also have something called the Chadwick sign. Okay? And the Chadwick sign, it looks like in this picture that the cervix is blue. And in real life, it also looks like the cervix is blue. It looks like when you look at it, like it's a cyanotic cervix, but it's really related to the increase in vasculature. And this could be a person can come in and say, I think I might be pregnant, or I'm having this discharge. You can say, no, you think you're pregnant? No, I don't think so. But then you look, and if you see this blueness, there is not anything else that causes the cervix to turn blue. Normally the cervix is red or pinkish. This is blue, and you're like, let's do a pregnancy test because this is Chadwick sign. The other thing that can happen is we can have this eversion where you can see here we've got the cervical os. So this is discharge here, that's the normal discharge in pregnancy, but the cervical os seems to protrude out a little bit. That is normal as well. And then something called ectropion can occur with the cervix. And this is usually due to increase in progesterone, and we have a change in the cervical mucus as well. Now this ectropion, normally when you do your vaginal exam, you do your cervical exam, you insert the speculum, and the speculum has to go in fairly far to find the cervix. Well, as mom gets further and further into pregnancy, that cervix propagates and moves its way externally. So for these patients that have significant ectropion, as soon as you put that speculum in, the cervix is right here. That is ectropion. So the cervix is right there, almost at the external portion of the vagina. Very, very interesting. Okay? And also very strange. Very interesting and very strange. And so again, these patients also have this increase in cervical mucus. They'll create this mucus plug between the internal os and the external os. And that mucus plug is there to help prevent infection. Mom may have a bacterial infection or candidiasis in the vaginal area, but they have this mucus plug to help prevent that from getting up into the uterus and affecting the uterus and the baby. By early on in pregnancy, the baby is protected by the maternal pelvis. Okay? But by about 13 weeks, the baby has outgrown that maternal pelvis, which means the baby, the uterus, and mom are at higher risk if there's any sort of trauma to the abdomen after 13 weeks. The other thing that happens, as I mentioned earlier, the mom's uterus is going to grow, the baby is going to start to rotate to the right a little bit, and that's why it's important when we talk to our patients, and we talk to them about staying on the left side and not the right side. Because on the right side, they're just going to put more and more pressure on the vasculature. Okay. Again, if they're in any sort of vehicle accident, even if it's a minor fender bender, I was hit from behind, or I just, I was going 5 miles an hour, I hit the person in front of me. Anytime there's any sort of trauma to the abdomen after that 13 weeks, there was a potential that baby could be impacted. So we take those patients as a serious risk. Anytime they come into the trauma bay, the entire OBGYN team has to come down and see them. And they are the ones that have to clear them before they can be discharged out. The uterus is designed to house a baby. The uterus is designed to contract. Okay? Now, sometimes we'll have what's called Braxton Hicks contractions. And what Braxton Hicks contractions are is false contractions. But it's the body is really practicing for the real contractions. So the mom is contracting, but they're irregular contractions. They're occurring 10 to 15 minutes apart. Okay? And most importantly, we don't have any cervical change associated with that. Meaning we don't have dilation of the cervical os. If we have dilation of the cervical os that occurs over a couple of hours, that is not Braxton Hicks, those are real contractions. But Braxton Hicks are very low volume contractions, not enough to bring about cervical change. Okay? So again, it's just the body is practicing for the real thing. And this can occur very early on. So in that second trimester, mom can start having these Braxton Hicks contractions, and they can continue on through the third trimester as well. Okay? Usually, they last, maybe they occur every 10 to 20 minutes. and there's really nothing to do about them. We talked about making sure she's hydrated, and of course talked about what real contractions feel like, or if they have any concerns, I mean, just not tell them to go into the antenatal unit. We have increase in vasculature of the vaginal area, the vaginal tissue, the perineal area as well. And we already talked about that Chadwick sign that we may see. The other thing that we may see is an increase in something like vaginal candidiasis or even bacterial vaginosis in pregnancy. And that's because we have increase in lactic acid production. We have the increase in lactic acid production. That means the vaginal mucosa, the vaginal tissue, and the discharge is more acidotic. We don't have that protective barrier anymore, and so we have an increase in risk for these patients that have infection in that second and third trimester specifically. And we've got some other vascular changes. Most commonly we're going to see is varicosity. So it's not unusual for a pregnant woman to have varicosity. They can have them in their upper thighs, they can actually have them in their vulvar area, or they can have them in the form of hemorrhoids. Okay? I always like to teach this around the time of Christmas because I say anybody that has a pregnant wife, you can give her this nice belt for Christmas. Okay? This is sold on Amazon and it's to support her. So you can say, look what I got you for Christmas, and a vacuum too, right? But this belt is supposed to hold things in and make sure we don't have any swelling or varicosities in the vulva or the upper thighs. But probably not going to work all that well. We can talk to our patients though about making sure they're doing their rest periods, especially in that second and third trimester. We can prescribe elastic stockings. Okay, they're very, very uncomfortable though, especially for moms that have an increase in that swelling at the end of the day. And then ultimately, if they need any sort of surgical intervention for varicosity, sometimes they'll have hemorrhoids that don't go back in, or they have prolapse, thrombosed hemorrhoids. They can have surgical intervention. We usually get to wait until after pregnancy for that. And then here's the hemorrhoids I was talking about. About 40% of pregnant women will have some degree of hemorrhoids throughout pregnancy. Unfortunately, hemorrhoids is one of those things that they may go away, but they often come back. Once you have a hemorrhoid, typically, once it goes away, it just kind of hides inside the anal sphincter, and then the hard bowel movements or another pregnancy, they come back out in rare form. Okay? So typically nothing specifically to do about these as long as they're not thrombosed. If they are thrombosed, it's an in-office procedure. We can cut those out and take the blood vessel or the blood clot out, and that will help. Otherwise, topical anesthetics like Proctofoam, we can do Dibucaine, you can do intrarectal hydrocortisone, anything like that typically helps. Or you can we have sitz baths that are available in the military system. You can send them home with a sitz bath. And then stool softeners are really important. We talked about iron supplementation causing constipation, so we recommend stool softeners from the very beginning, and especially in the setting of hemorrhoids. If we can give these patients stool softeners early on, we can reduce their chance of even getting hemorrhoids. All right, the endocrine system. Let's take a break and then we will go with our endocrine system and then we'll finish up. The changes that we're going to see for our endocrine system, they're going to assist with fetal survival and also prepare mom and mom's body for the laboring process. So we're going to have a decrease in our albumin levels. That's usually more due to a dilutional hypovolemia that we're going to see. The pituitary gland, much like the kidney, actually increases in size. That's due to increase in estrogen, increase in progesterone as well. We have an increase in hyperplasia. We have hyperplasia of the lactophil cells. And prolactin levels are going to increase by about 10 times normal. For patients that are breastfeeding, we are going to have a decrease in those the prolactin levels after pregnancy. Even if they are breastfeeding, we're still going to have that decrease, and usually within the first couple weeks they'll go back down to normal. There's going to be this pulsatile burst of prolactin that's going to be released, about 6 months postpartum is when those prolactin levels go back down to normal. The thyroid, so remember the thyroid and HCG are structurally similar. So as the HCG levels increase, we also have an increase in our TSH, our total T3 and our total T4. Okay, the free T3 and free T4, those levels remain unchanged throughout pregnancy. And it is important that we have this change in the thyroid levels because it helps with neurodevelopment for the baby. Parathyroid levels. Now, parathyroid levels, think of them about an inverse to calcium. So as calcium levels, we know they're decreasing, parathyroid levels are actually increasing. Okay? And this is important for appropriate fetal skeletal development to have this converse relationship with PTH and with calcium levels. The pancreas, we have this persistent or progressive insulin resistance. In order to divert glucose to the growing baby, so to compensate for that, the pancreatic beta cells, they're going to increase the amount of insulin produced. So we're going to have this insulin resistance in pregnancy. If we do not have that insulin resistance or these normal adaptation processes, that's when we run the risk of gestational diabetes if someone's body is not responding like it should. Our adrenal glands, they don't undergo a ton of change, but we will see an increase in cortisol levels, especially around the time of delivery due to the stress that's associated with the delivery. And then we also notice that the increase in cortisol levels help prepare the body for that laboring process. Androgens, they pretty much are maintained throughout the pregnancy. We have increased levels as mom gets further and further into pregnancy, but we're not exactly sure what role specifically androgen plays, but maybe to prepare the body for labor as well. We've got some breast changes. We know very early on in pregnancy, sometimes that's the first sign patients have that they're pregnant is they have breast tenderness or they may notice some breast enlargement. But usually within the first couple of months, we're going to have an increase in size. We can have an increase in vascularity as well. And then those skin changes that we ought to talk about. We have a hyperpigmentation around the areola and the nipple. After the first few months of pregnancy, we have this colostrum that can be expressed from the nipples, and this kind of this thick yellowish fluid. And then the areolas kind of get wider, and then they have the hyperpigmentation. There's also something called these glands of Montgomery around the areola. And what it'll look like, it almost looks like little pustules or little pimples around the areola. But they're non-tender, and it's just a hypertrophy of those glands. Nothing to do about them. Don't go incising those unless the patient has clearly an abscess, and that's something different. These are just pronounced glands, sebaceous glands around the areola. Hematologic changes. We already talked about that. Blood volumes are going to increase by about 50%, and that's going to be early on in pregnancy. Even by about 6 weeks, we're going to start seeing those hematologic changes. And because this is a dilutional hypervolemia, our H&H numbers are actually going to decrease. So it's going to look like they might be, maybe some of these patients might look like they're borderline anemic, but they're really not. It's just that hypervolemia. We also are going to have a progressive leukocytosis. It can be 15, it can be up to 25 for your unless you're WBC specifically, up to 25 around the time of pregnancy and early postpartum period. So don't be surprised. Again, if someone comes in and they're complaining of something that you may think they have an infectious process, and for those of you that believe that you must look at a CBC to tell you if someone has an infection, that CBC is going to give you false information because it's already going to be elevated. And so you should not determine if someone has a bacterial infection based on their CBC. It should be based on their signs and symptoms and potentially what they were exposed to. Platelet counts are going to decrease, right? And again, due to hemodilution and also due to increase in destruction. RBC volume increases. Iron requirements increase significantly. And then remember, for these patients, they do have a higher risk of stagnation of the blood. We want to make sure that we have understanding of their risk of thromboembolic events, DVTs, and pulmonary embolisms, not only in pregnancy, but in the early postpartum. As a matter of fact, DVTs and pulmonary embolisms are most common in the early postpartum, the first 6 weeks postpartum. So you want to keep that in mind for patients that come in after they deliver, chest pain, shortness of breath, lower extremity swelling. Those things should not be occurring after pregnancy. So you want to think about the increase of VTE. We also, because this pregnancy places mom in a constant inflammatory state, we have a baseline increase of non-inflammatory markers. ESR, CRP, D-dimer, C3 and C4 increase. So that means we really can't use those labs, again, to help us rule in or rule out inflammatory processes. Someone comes in, they've got a red hot joint. Well, we love to look at an ESR and CRP to help us to see if we think this is a septic joint versus gout. But unfortunately, in the patient that's pregnant, those lung nodes are going to be elevated. D-dimer, we don't use D-dimer in pregnancy, although there's been a lot of literature lately about modifying the number for D-dimer in pregnancy. So it'll be interesting to see in the next couple of years where that takes us, to see if we can just use a higher number in pregnancy to help us rule it in or rule out DVT or pulmonary embolism. Ultimately, if we think these patients do have a DVT, we can do an ultrasound. If we have a pulmonary embolism, then CT scan is typically recommended. We used to talk about VQ scan a lot. VQ scan actually has more radiation now than a CT scan does. VQ scans are not readily available. The patient must be admitted to the hospital for a VQ scan, so it's a big deal. If they have an allergy to contrast, then they'll bring them in and do a VQ scans, otherwise CT scan is what's done. The spleen enlarges pretty significantly during pregnancy. And so look, we get almost a 70% increase in the size of the spleen. Well, that's often due to an increase in blood volume. And the issue that we have is, as long as mom has an uncomplicated pregnancy, she doesn't have any trauma, probably no big deal. Okay? But let's say mom gets mono in pregnancy. Okay? What does mono do to the liver and the spleen? Increases size. So we do have a potential for a rupture. If mom is involved in an MVC or abdominal trauma, and the spleen is 70% larger than it normally is, significant increased risk of splenic rupture. Keep that in mind. Again, when these patients come in with what seems like a very minor accident, a very minor fall. I was walking down the stairs and I slipped, I landed on my butt, I didn't hit my abdomen, but still that jarring and that trauma can cause intra-abdominal complications. Dental changes. We already talked about the dental exam being part of the initial screening, that initial OB visit. Okay? And the reason for that is because women that are pregnant do have an increased risk of gingivitis. Okay? Those gums become softened and more inflamed due to a change in the estrogen and progesterone. There is something called did you guys hear about pyogenic granuloma? So pyogenic granulomas, once you see it once, you will never forget. Those things bleed. Even if you look at it wrong, they will just start to bleed profusely. So these patients may come in, they can get pyogenic granulomas of the gums. That is terrible because they've got to brush their teeth, they have to floss. And anytime they touch this, it's going to bleed. Unfortunately, there's not a lot that you can do about these, especially in pregnancy. Okay? So you just talk to your patients about trying to avoid that area and being really careful and putting direct pressure on there. Okay? Pregnancy itself does not increase tooth decay. It is if mom is not performing appropriate dental hygiene that increases tooth decay. Okay? And oftentimes related to what they're eating as well. CNS changes occur. Okay? We talk about patients that have been pregnant, they have a decline in memory throughout the pregnancy, most notably in that 3rd trimester. And when we ask patients and we look at the literature and say, well, what exactly happens? They talk about this decrease in verbal recall, a actually they have a reduction in speaking speed because they have to think about what they say before they say it. Otherwise, they're like, what did I even just say? I don't even know what I'm talking about anymore. We can attribute this somewhat to sleep deprivation, sometimes anxiety and depression associated with the pregnancy and ultimately deliver. But in addition to those things, we have distinct memory sources. So even if someone says, I have no anxiety, I have no depression, I'm sleeping great, those patients still tend to have memory changes that occur in that third trimester. Right? Not permanent, they typically resolve within the first couple of weeks after pregnancy, but certainly can be frustrating for the patient and frustrating for the spouse as well. So we just talk to your patients about it's a normal process of pregnancy due to all these hormonal changes, especially as you're getting ready to deliver this baby. Okay. Ocular changes. We have an increase in vitreous outflow, decrease in intraocular pressure. Okay. We have a slight thickness, increase in thickness of the cornea. Okay. And that's usually due to the amount of fluid that mom is retaining. And what that may present as, patients may say, I'm seeing fine, but I feel like my contacts are not fitting very well. Like they don't seem to stay in place, or I have a hard time getting them in. And it's really just that. It's not that their vision, it has no impact on their vision, of course, unless they can't wear their contacts at all. But they put the glasses on to see just fine. It's just that the contacts just don't seem to fit right. But vision is okay. Again, sleep. Everybody, most people that are pregnant have a difficult time sleeping, and that is early on from that first trimester all the way through pregnancy. Oftentimes they have not only a difficult time going to sleep, they have a difficult time staying asleep, and a difficult time finding a comfortable position, especially in that second and third trimester. Okay? And so we want to talk to our patients about ways to help them sleep better. And patients can take melatonin, but also Unisom is very safe in pregnancy. We have to talk about Unisom for patients that have nausea and vomiting, but Unisom helps with sleeping as well. That is actually what it's designed for. So they can take that to help them sleep. Okay? If patients are not sleeping, it increases their risk of depression in pregnancy and in the postpartum period as well. And that is it for today. Thank you.